So first, I just cannot tell you how much fun I'm having and how excited. It's so great to be with you all, but it's also been a goal of mine to have Paul here for many years, and probably of all of the people kind of in international health and international development, more people have asked me to try to get Paul here than
Wait,
I
it
think
doesn't
anyone.
count that I call in from other countries?
No, but this is really special. And the other thing that's so special, and I'll ask him in a minute to stand up too, is we've got a whole group of partners in health folks from around the world too. So it's a wonderful treat for me, and I know it's going to be a really powerful, wonderful treat for you. So I know Paul Farmer needs no introduction, but I'm going to introduce him anyway. So, I mean, the part that you probably know is that Paul is the co-founder of Partners in Health. He's a physician, he's an anthropologist, he's an author of more than half a dozen books. But, I mean, the other part that you do know if you've read his books, but I want to say it anyway, is that he's just an incredibly passionate, effective advocate for his patients, for social and economic and health justice. And he's a fantastic advocate on the Hill as well. I'm going to say more about that in a minute. He's also willing, he does the work, he does the health work, he's proved that things are possible, but he's also willing to call out injustice where he sees it. And that's been, and he's willing to fight for things, and he's willing to make change and push for things that people said were impossible. Partners in Health pioneered the treatment of MDR-TB and AIDS in resource-constrained settings from rural Haiti into the poorest neighborhoods in Peru to Lesotho and other places when people were saying it was impossible. And I just want to share one vignette, which is that in 2003, Partners in Health, working with partners in Haiti, Loon and others and many others, brought over 200 people, health experts who didn't believe treatment scale-up was possible, U.S. government officials, Congressman Jim McDermott, and then Congressman and now Senator Sherrod Brown, first to Port-au-Prince, but then trooped everybody up to the central plateau of Haiti, where in Conge, where Partners in Health had a facility, and had been doing this kind of work to show that treatment scale-up was possible. And folks got to spend a couple of days there and see people who had literally been brought back from near death, who were not only alive, but who were community health workers and treatment accompaniment folks, and who were making this possible for other people. And I'm absolutely convinced that kind of going from that few 100,000 people who had access to AIDS treatment to where we are today was really in part triggered by the work overall, but by that particular moment. And I was showing Paul that I actually have a t-shirt from that trip. And so, April 2003. And they have this silly thing, they probably have in other places too in the US, where people say like, my parents went to Florida and all I got was this t-shirt. So I feel like, I was looking at this t-shirt, which my husband saved. He's really good about that. He doesn't throw anything away, and I was so happy we had it. But I was looking at this t-shirt and I thought, I went to Haiti and what we got was this t-shirt and 17 million people on AIDS treatment now. So, I want to say that Paul's also one of the most effective. I've had the real pleasure and honor of going to the Hill with him, and he's one of the most effective advocates that I've ever worked with, and he's really willing to use his time and his energies to also make this case to policymakers in the U.S. and around the world, and I feel really lucky to have him both as a friend and an inspiration. So welcome, Paul.
Thank you, Joanne. Thank you. Thank you.
And could I just ask the PIH folks that are here from around the world and from Boston, can you just stand up for a moment? Because we've got a whole great PIH Partners in Health family here. Welcome. We're so thrilled to have you. So Paul, if it's okay, can I jump into like a first question and then you can say whatever you want?
Sure.
But
I'd like to know first, why are our Mexican colleagues here? They're not. Aren't they supposed to be working on a project, an infrastructure project? Hugo? Sorry. He makes that joke more than I do. And infrastructure is important. Anyway.
Gray matter infrastructure. One of the reasons that I have such enormous respect for Partners in Health is not just what's been accomplished, but how it's been done. And you created Partners in Health with a commitment to a preferential option for the poor. So in line with some of what we were talking about earlier, can you just say like what that has meant and how you've designed your work and how you've done your work? Just talk about that principle.
Well, you know, I think the way you said it was beautiful. And the cartoon, I mean, I know how much you're into sports, Joanne, just like me. I was actually a power forward at Duke back in the, I'm kidding. I don't even know what a power forward is. But, you know, it's an important point to be made. That's not where, we did not stumble across that expression, preferential options of the poor, by reading policy documents, right? Or by thinking about equity in a way that would be very fruitful, right? This is not only the right thing to do, but also a very strategic way of seeing resources make a big difference. We borrowed that idea, as you know, but I'll pretend you don't in the interest of a conversation, from liberation theology. And you know, I'm not a theologian, nor could I play one on TV, but the idea that you would actually devote the most of your attention, most of your passion, your commitment, your affective and economic engagement to people living in extreme poverty was very compelling. At least it was for me, and I learned that from Haiti, which has been my biggest teacher. And if you're a physician and you just follow the epidemiology, then it's also a prudent strategy, because whether you're looking at cancers, and there are many kinds of cancer, or AIDS or tuberculosis, or fatalities due to trauma, it's also much more heavily, all of those are much more heavily concentrated among the poor. So focus on the poor makes moral sense, it makes policy sense, and it makes certainly sense in medicine. And I feel like we were very lucky to learn that when we were young. That's why I say it's Haiti that taught me that. And when we started Partners in Health, when most of us were students, we wrote a mission statement that we're still proud of today, because it says that that's where the majority resources would go. In more colloquial terms, and my colleagues in Rwanda are here, and will remember this, but you know, we were starting to work there. I had been going there for about 15 years, and we moved there, a lot of us, and mostly the we was Americans and Haitians, because we've been working, and the occasional Peruvian. We even let in a Mexican over that wall. And then our new partners who were Rwandan. And, you know, we said, one of the questions that I was asking, because a preferential option for the poor made so much sense in Latin America. That's where those ideas came from, right? But we asked this rhetorical question: why is it that the worst tourist hotel, even here, is better than the best public hospital? And everywhere we go, we keep seeing the same thing. And that's kind of the neoliberal trick, right? That it's okay for the worst tourist hotel to be better than the best public hospital. And so that's, you know, that's preferential option for the poor in healthcare when you're fighting that. And you're also fighting other noxious forces like the ones you described for this country. And so anyway, we're glad that we weren't wrong in our youth, and have learned a lot along the way how to do it better. Is that too long an answer?
That was a great answer.
Concision is not my strong suit. And it's 8 books, not 6.
I said more than half a dozen because I wasn't sure. I wasn't sure if I was keeping up.
You didn't read The Global Threat of Drug-Resistant Tuberculosis, clearly.
I have it on my shelf.
You're probably the only person who did read it.
Just sort of building on this, the sort of origins and how you do your work. I mean, another central tenet of the work that you do is accompaniment. So can you sort of just say more about, and your partners will have a chance to talk about that too, but just again about how you work with countries and how you support, build models but support national systems. Like, can you talk about what you've learned from that, and just again that's the sort of driving principles, because I think we're also looking as we advocate for what is going to make the biggest difference in the world and how should we do this work, not just how do we get more resources, but make sure those resources really build something that lasts and matters.
Well, I need to give credit to my Haitian colleagues and teachers. I was 23 years old, living in a squatter settlement. It was vivid and different, I hadn't really been outside of the United States, except for France, which doesn't count. I hadn't Brexited. Anyway, I would like to say, if I may, Loon, at least stand up and wave, because Loon Vio is my hero, and I've worked with her for 30 years, so you look at her and do the math at how young I recruited her. The Haitians I was around, and I wasn't, I didn't know anything about policy circles. This was out in a squatter settlement in a rural area. There was no electricity or running water. Many of you here have fought against those conditions, which are inhumane and all too widespread. But the word accompaniment is used often in Haitian Creole, and then again in this liberation theology literature that was coming out of Latin America, the struggles, the very violent struggles. When I was a student in college from 1978 to 82, Central America was, there were terrible wars going on. Apartheid, of course, was still a dozen years away from beginning to be dismantled. And so it was these two poles for me, and a lot of my colleagues, certainly the founders of Partisan Health, experience in Haiti especially, and later in Peru. I have a deep debt to Peru as well, and to my colleagues. Again, some of them are here. And on the other side, I unlike the people living in this squatter settlement, when I left in 1984, it was to go to Harvard Medical School, and they're still there. And in those first years, I can tell you I know we did a lousy job. First 10 years probably. How can I tell you? Because in spite of the noble intentions, accompaniment, understanding the burden of disease, addressing gaps, I was working with quite a few people my age, young Haitians. There was a team of about 6 or 7 of us. Ophelia Dahl from, grew up in England, was often there. And of the 6 young people on this team doing a health assessment, before I graduated from medical school, 3 were dead. 1 of obstructed labor or an infection right after, something I never have seen at the Harvard Teaching Hospital still. And I trained at the Brigham and Women's Hospital, the largest women's hospital in New England, in terms of births in any case. And the second one, and I was very close to these 3 people. The second one died in a psychiatrist's office, misdiagnosed of having psychosis. She had cerebral malaria and dropped dead right there. Beautiful person. And the third, this passionate young guy who I traipsed over all of that part of Central Haiti with, died in pain on the operating table of a perforated guts, basically, from typhoid fever. So, we knew we were on the right track. By then we had already built a clinic in a squatter settlement, and Zami La Santé, the sister organization. That's how Partners Health works. We're building sister organizations, not daughter organizations, right? So Zami La Santé is Haitian Creole for Partners in Health. And Shuti Mubuzima is Kinyarwanda for Partners in Health. Socios and Compañeros en Salud, again, Spanish. So we had done a lot, but that's pretty horrific to lose 3 of your friends and age mates to preventable disease, but also treatable disease. And that's why the treatable disease part, like even at the end, when you already have this infection after you've given birth to a child called puerperal sepsis, the one I've never seen, or you have cerebral malaria and a coma, or you have ileal perforation from typhoid, you can still be saved by a good hospital, you know. And so, all along the way, accompaniment, prevention, care. If we didn't have community health workers, clinics, and hospitals able to take care of the critically ill or injured, we hadn't succeeded. And what's more, we saw the collapse of the Haitian economy in those years, again through policies, and the collapse of the already weak public healthcare delivery system. So we started thinking, okay, what are we doing wrong? And how can we get back on track? That's when you and I met, you know, to think about policy, to think about helping public sector institutions so that the worst tourist hotel didn't look better than the best public hospital, and how to have long-term accompaniment regardless of the type of health problem or poverty-related problem that we would come across. And that's been the last 20 years, but not the first 10. We tried. We needed more partners, we needed more resources, we needed to listen more, to learn more. And in fact, if we, even just listening, reverent listening to the people that you're taking care of, they'll tell you all these things.
Building on what you also just said about the sort of policy piece and the resource piece, so a couple of things, right? You all demonstrated in Peru what was possible on MDR treatment that people didn't think was possible. You demonstrated in Haiti what was possible on AIDS treatment in low-resource settings. And you've been willing to and smart about not just doing the work, but kind of making the case. And you've also been extremely generous and willing to kind of come to the Hill and traipse around the Hill and talk to members of Congress. So I just, you know, to this room of advocates, I guess.
Oh, that's my favorite part of the work.
Can I just say he's actually really good at it. We went to this. They were in town. It was earlier this year, a couple of months back, and we went to meet with this senior Senate staffer, and we shouldn't mention the name, okay? But who's actually very, very committed and like really cares about these issues, but is a very morose, not very happy person, affect. And so I always kind of, you know, and I know they care about it, so that you sort of connect with that piece. So we go into the room, I go into the room with Paul, and the guy is just like as happy as I've ever seen him, and we have this chat, and he's going on, and he's like, other people are waiting for him, and he doesn't want to leave, and I was like, I have never in 20 years seen this guy do that, so I always want to bring him to the Hill with me.
I gave him a hug too, by the way.
But I mean, I guess my question is sort of to this room of advocates, you know, you joke about it, but you don't necessarily, it's not your favorite thing, but you do it. So, yeah. I mean, just talk a little bit about why that, from your perspective, the advocacy matters, and why the resources from things like the Global Fund have mattered to the work that you all do.
Well, you know, I don't want to underestimate our interest in policy as a collective. I mean, Jim Kim, people say to me, aren't you shocked that Jim Kim is president of the World Bank? I said, no, I'm not. You know, not at all. He's always been interested in poverty and policies on a grand scale that could alter it. Well, we started at Partners in Health, even though we were already on the faculty of Harvard Medical School. Some of us, we started the Institute for Health and Social Justice in 1994, which was designed with the idea that progressive efforts to promote health and social justice needed to be sound in terms of, you know, our understanding of complex problems. And I'm sure you all read that bestseller of ours, Women, Poverty, and AIDS. Yeah, you're the only, it's like one sale in the city of Washington. I know who bought it. No, but you know, we had we would try. I mean, we had a seminar series for a year. What we would do with that we would study gender inequality, poverty, how they conspire, right, through exclusion, to create extraordinary risk for that particular disease, and that was in wealthy countries and in poor countries. You know, gender inequality, racism, poverty, and then how they conspire once someone's already sick to make it less likely they would get care. And that's it's like doing our homework. And results, you know, I turn to results because that's the homework gets done by results. You want to know something about the numbers or about where we are with TB or health system strengthening even, you know, it's not, you need to have reliable sources, as you pointed out in your lovely remarks. But we knew early on that it wasn't enough, for example, for those of us who were in a university. I'm a volunteer for Partners in Health and have always been a volunteer. I had a day job as a doctor. And by the time they noticed I was never in Boston, too late, I was tenured. So we also knew that it wasn't going to be enough to do those, you know, write an article in the New England Journal of Medicine about how important it was to, you know, take on the 3 major killers of the world. This is all pre-Global Fund. And you know, the struggles from Peru were very, very painful. And some of my colleagues, one of them who's here, I was just reading some of her words yesterday about how excited she is to have, for the first time in 40 years, 2 new drugs for people who have drug-resistant TB. So we're like yelling and screaming, which isn't very effective. We're also treating patients, right, who were deemed untreatable. But and there's a victory narrative way of reading it, right? You know, change the policy, et cetera. But it doesn't matter if there's not implementation. And right now we have a huge problem, as you pointed out, with drug-resistant tuberculosis. So looking back on that effort to take care of the sick, our job, and our Peruvian colleagues' jobs, to alter policy that was ridiculous and unscientific and unbuttressed by anything except the, you know, neoliberal worship of cost effectiveness, we still have millions of people who need therapy for this. Now, the big change for me, though, you were in on this one too, was PEPFAR and the Global Fund. And when I was drafted to go and write one of the MDGs, of course I said, what's an MDG? I mean, is that like MVP sports? Is it like a draft for a sports? I knew it wasn't that. But that's how I met our chief co-conspirator in Rwanda, Agnes Binagwaho. I mean, that lady's formidable, let me tell you. And we got involved in a policy effort to write the MDG about AIDS, and she chaired it. Both of us bonded and became close friends because part of that experience was very, I believe a psychiatrist would say, ego-dystonic. It wasn't fun. There were all kinds of arguments. They're the same arguments you're still facing now that Results is fighting against. Like, well, it's not cost-effective to treat patients, or we've got to put all our, you know, efforts into prevention. And we would say things like, yeah, but some people are already sick. You know, and I mean, one instance I was trying to illustrate, and a lot of these people, by the way, these policy folks were from Africa, and they weren't fighting for treatment being included, all of them. The AIDS activists were both African and North American, European, but these are experts, and they were experts in health and development, and they had a very low-ball view of what should be done. Their favorite words were basic minimum package, right? And it was so minimum, it didn't include any treatment for AIDS, or drug-resistant malaria, or drug-resistant TB. Forget about cancer or trauma of the seen or unseen kind. The seen kind, meaning violent trauma, is the leading killer of young adults in much of the poor world. So neither of us loved the process, but even this meeting was stressful to me. You know, having 200 of your closest friends from Washington show up in a squatter settlement in rural Haiti. Thank you, Loon, for medicating me with whatever it is you were giving me. It was a lot, you know, for my Haitian colleagues. But that year, the birth of the Global Fund, and I remember talking about it with you as it was being born, and making plans in Haiti for the first major Global Fund grant went to Haiti, then in disarray. and it was successful. And then came PEPFAR. I thought when I was invited into the White House that I said, really? I was in Haiti. You really want me to go there? I mean, won't they know? I'm glad you got my sense of humor there. And it was a great experience, you know. It was interesting to me that the biggest champions, though, again, were not the experts in policy and health and development. It's actually some unlikely politicians, I thought, and I was wrong. So those two experiences, even more than the work on TV, which remains a grueling struggle, those two experiences, they changed our lives. Obviously, it changed the lives of 17 million people and many more. That's just people on therapy. I mean, there was every reason to believe there would be a huge epidemic of HIV among children in that year that those two institutions were born. And I can tell you, and I've got my colleague, Tony, is here. Tony, give a little wave. Hey, Tony. In one of the 3 districts that we were sent to in Rwanda by the Ministry of Health, and one of them is called Karehe, and it had no hospital and no doctor. And so we said, we're here. Community health workers, clinics, it's got those now. And I don't think in the last 2 years there's been a single case of HIV transmitted from mother to child in that district. I mean, that's amazing to me. So, and of course, that's the Rwandans. And I'm just saying, those are policy decisions that have saved hundreds of millions of lives and prevented all kinds of bad stuff from happening. And we really have a long way to go still. I know, again, incision's not my strong suit, but that experience forever silenced me as a critic of, policy work, because I knew that we could never make that kind of difference with hundreds of thousands of community health workers, nurses, and doctors. We needed to have the resources. So thank you. The student movement, by the way, I knew you were going to go there. I'm going to say results, Face AIDS, later Global Health Corps, GlobeMed, obviously ACT UP, Treatment Action Campaign. I mean, that's where our allies were, right? Because they weren't saying, let's have a basic minimum package. Here's what's in it. They were saying, we want equity, and we want justice, and that was our fuel, right? And I'm not just talking about for illnesses, jobs, education, etc.
And in a couple of minutes, I just have a couple more questions, and then I'll open it up to folks, because we've actually got some time.
I mean, I came here all the way from Sierra Leone. I'm going to stay as long as I want.
I love this. We were actually afraid he had to get on an earlier flight, but he doesn't, so we've got time. This is great. Paul, as you well know, the world's attention for a while was intensively focused on Ebola, and on West Africa. But I was going to say I'm not sure we've learned the right lessons. I'm pretty sure we haven't learned the right lessons. But can you say a little bit about the lessons that you all have learned about actually what's needed for this? And I think, because again, we're trying to, we're talking to policymakers about what's needed to prevent this stuff in the future and to sort of provide universal health coverage for everybody.
I'd love to.
What comes out of that?
The thing is, in my line of work, you have to be an optimistic, even if it requires substantial psychiatric assistance and medication. Since a number of you are students, I do want to tell this story that I only recently was mature enough to tell. When I, for reasons that are completely unknown to me, I knew I wanted to be a doctor. I'd never seen a doctor growing up. I had a broken arm. I saw a doctor. And I went to the emergency room. My father, by the way, didn't want to take me. He said, I can set that. He was a school teacher. I said, no, Dad, you cannot set my broken arm. But the doctor may have been a little bit inebriated. So my only experience with medicine, I mean, I still can't bend my arm. I had no reason to say I wanted to be a doctor. Good thing no one asked me when I went to my interview at Harvard Medical School. And I wanted to work in West Africa. I'd never been, I told you, to Africa. And I said, yeah, I want to be a doctor and work in West Africa. So I applied for a Fulbright. And I think everybody in this room, including the non-Americans, know about the Fulbright grant because they go both ways. And I said, I'm so smart. I have such good grades, gallant, charming. I'm sure I will get this grant. I didn't even get an interview. So Haiti was plan B. And that's the best thing that ever happened to me. And it took me about 30 years. Yeah, I mean, you're getting that I love Haiti. But I still wanted to go to West Africa. I've been to Senegal. I've been, but just for short things. Medical conferences don't count, right? And thank you for affirming my critical doubt about training the trainer conferences, beloved of our national funding agencies. And I was organizing, guess what, a medical conference. But I had a plan, because now, it's 30 years later, I'm the chairman of a department at Harvard Medical School, and I have a friend, in fact, 3 friends in Sierra Leone. And it was a surgical conference. And Scott knows some of the folks that were organizing it. And the first meeting is a British medical journal sponsors this, The Lancet. I'm sure you all read The Lancet every week, right? I've noted before that we have downwardly mobile journal names in medicine, The Lancet. The main gastroenterology journal is called Gut. So, in any case, we were organizing a surgical conference, and the first meeting was at Harvard, and the third meeting, for reasons I won't go into here, was going to be in Dubai. So I said, and this is about surgery for poor people. So we said, the meeting has to be in Africa, and not Rwanda, which is already on the right path, or not South Africa, because South Africa has far and away the most ability to host a conference, right? It's the most, and I, trust me, I love going to South Africa. I said we need to do it in West Africa, Liberia, Sierra Leone, and Guinea. And because I'm an infectious disease doctor, I knew what was coming. We knew since March 2014, and this meeting was scheduled for June 2014. We knew since March, at least, a friend of mine was in it. I had three Sierra Leonean friends. One sitting right there, Violet Berry, my student, and friend for almost 10 years, who was then at Harvard studying with us. An infectious disease colleague who was an expert in, guess what, hemorrhagic fevers like Ebola, and a surgeon who was working with us on this Lancet commission. And so I said, we're not canceling, we're not moving the meeting from Freetown. You do not get Ebola by attending medical conferences. Now, it's not entirely clear that you get any medical information either, but I had promised Byler for years that I was going to go there, and you can't just say to Partners in Health, oh, now we're going to work here. And there's 15,000 employees. We run 100 and something health facilities. It's hard to move quickly. And but by November, 2 of my 3 friends were dead of Ebola. And I can say that summer, and, I mentioned the 3 young people of my friends who died in Haiti. As you pointed out in talking about the Houston Chronicle, personal engagement is personal, right? And, for the only Ebola expert in that part of West Africa to die of Ebola, in very bad circumstances, I might add, that's when I knew that, I was going to, that was a turning point, July 29th, 2014. So you ask about the lessons learned about Ebola. Well, guess what? They're the same lessons we learned about AIDS, tuberculosis, any vertical program, right, is you need a health system. Remember I said the first 10 years of our work in Haiti? So it was when we turned towards strengthening the public sector system, not building a parallel system. You know, University Hospital in Mirebalais, which is beautiful, I might add, we built it, Partners in Health built it, but it's for the Ministry of Health. And it's now the largest training center for Haitian doctors and nurses, and one of the largest centers probably in the Caribbean. Even our mighty rival Cuba, who always show up, by the way, they're good accompagnateurs. In any case, the lessons were not substantially different. That if you don't have the staff, the stuff, the space, the systems, then you cannot either prevent outbreaks like this or even know what's killing you, right? You need laboratory. You know, the main symptoms of Ebola are not, you know, blood coming out of your eyes. It's diarrhea, vomiting, and fever. How many things do you guys personally know, excluding the infectious disease specialists here, that cause those symptoms? I mean, everything, practically. So you need labs. And you know, it's great if someone isn't vomiting and can take oral rehydration. But, well, again, I just mentioned the nurses and doctors who died. They didn't die fleeing their posts. They died because they stayed at their posts even though they didn't have the staff, space, and systems that they needed. And so I guess I could say that, well, the worst part of the whole thing for me was that time between leaving Freetown in the third week of June, saying goodbye to you and thinking, and my other friends, including some, thinking, my friends are sitting ducks. And I was right. From June, the end of June, till September, when the Partners in Health Board unanimously approved our long-term commitment to Liberia and Sierra Leone for health, to stop Ebola, but for health system strengthening. That period was the worst. But part of the rest of it, first of all, it's been great working there. And people say, what? You like working on Ebola? I said, no, but I like getting to know Sierra Leone and Liberia and making friends and working together and seeing people survive. Because as with Haiti, in that conference you attended, that did make a difference. And I'm glad, I'm glad you say it. You know, it would seem unseemly for me to say that it made a great difference, but I knew it did. But the survivors, we started working immediately with survivors. And Byler and I, and you know, Ophelia, Joya, Beck Rollins, we went the next day to meet with people who could barely stand up, but they were survivors. And we started hiring them and working with them. So those were lessons learned with AIDS, you know. Those are lessons learned for us with other illnesses, TB. You know, in breast cancer, survivorship is a big deal, right? Here in the United States, we're trying to make that true in Haiti. You have to have staff, stuff, space, and systems to prevent women from dying from breast cancer. We don't even know how to prevent it, but we know how to treat it, you know, if we can diagnose it. So that was old lessons. I think the worst part, and here's something I would ask results to really take seriously. And you know how I was just tough on us about that our first 10 years in Haiti? By the way, when I went to interview for medical school, I spoke about our work in Haiti as like it was the, you know, God's gift to you name it. And the Americans have this funny expression, the best thing since sliced bread. But really, what's so great about sliced bread? The French are right on that score. You know, because I wasn't mature enough to understand that it was mediocre work. And I learned not to fool ourselves that just because it was enough or it was in rural Haiti that it was good. And so to see this all happen again many years after the tsunami and the Haiti earthquake and the AIDS crisis and malaria, pre-global fund, et cetera, because that's what happened again. It's still happening right now, right? To say, okay, the Ebola restricted funding is emergency funding and the emergency's over, not true at all, right? I've been to places where they said, we have 0 Ebola in our district. And I wanted to say, but I'm too polite, you have 0 laboratories in your district. You know, I don't do stuff like that because it's just rude, but it's also true, right? And, you know, we're still as bereft. You know, Partners in Health has settled in for the long term in Liberia but it's in a place just like in Haiti or Rwanda. It's a place. It's this extreme southeast, a town called Harper, which, by the way, looks like the war was over yesterday, not 10 years ago. It's a mess, right? And they don't have the staff space system. Same in Liberia. So we're sticking there, and we're still doing it. But part of me wants to say, shouldn't it be easier for us after all these years of being right on these scores, that you need health system strengthening, that you need accompaniment, that it is not a 6-month ADD-style emergency intervention, then poof, reallocate the money to Zika? And we're just not going to make it without you guys, because it's not the data. The data don't suggest that approach works to save people's lives and prevent misfortune. So Ebola is, yes, new to me, is in a place, and new colleagues and new friends, but old problems in the most connected part of Africa with the rest of the world. I mean, West Africa, first of all, there's a reason the Haitians look like the West Africans, but second of all, the whole Atlantic world system was built off the backs of that trade. And now suddenly we can't remember unless somebody comes in and gets diagnosed in Dallas with Ebola, and the whole country goes nuts. So we need your help on this, because we shouldn't have to fight to prove that health system strengthening, whatever we want to call it, and let's find a sexier term, I don't know, Beyonce. And we shouldn't have to fight so hard. So it's old lessons, and we need more of you to echo and amplify as you are doing. Sorry to get so personal.
No, thank
about
you.
Beyonce.
Do we have, if I want to open it up for questions, do we have mics? How should I, so we don't have a standing mic then, so if folks have a question, why don't you come out in the aisle, and we'll take, maybe start with like a half dozen folks lined up or something if you got a question, and then we can just share the mics.
Hi, I'm Lynn Catalano. I'm from Southern California. If you don't know, I'm a brat. I'm going to be a personal brat again. Hi, Dr. Farmer. I met you at the University of Redlands last year, and thank you for contacting my congressman, your protege, Raul Ruiz. I did get immediately contacted by his staff after your folks reached out to him.
See, that's one of the perks of being a Harvard medical professor. Yeah. How could he's my student. He had to do it.
He had to do it. But there was a problem. He had twins. His twins were born shortly then. And then my group went to meet with him face to face. And he was shocked that there was legislation that was going to work on maternal and child health. And we weren't ready yet to ask for him to co-sponsor it, because at that time the bill didn't have original sponsors, and we were looking for it to be bipartisan. And then last summer when we came to the conference, we met with his staff because he had to go vote. And we weren't ready because we were looking for it to be bipartisan, and we needed Republicans on the bill first.
I'm sure it shocks everyone that my student is a Democrat.
Yeah. And then I didn't do my job. So I'm going to be a real brat, because we haven't annoyed, pestered, badgered, bothered, reminded his staff.
Yeah.
And his staff, I don't think, know that he is an international medical crisis intervention doc. They don't know that. And so we haven't gotten to him, and I'm wondering if you could make a call again to his office. Because here's the thing. Results is about to, wait, because we don't want to take too much time. Results is about to move out of committee this bill for maternal and child health, the REACH Act. And it will break my heart if Dr. Ruiz is not at least a co-sponsor on that legislation when it makes history.
Well, consider my part done. This guy is, as we say in scholarly terms, a total sweetheart, and a health and social justice person since before he even started medical school. And he did not grow up in favorable circumstances. His heart, but it's kind of what I've seen, because we have some really good close personal friends actually in Congress. I mean, meaning they are in Congress, semicolon, they are actually good and close friends. And, you know, it's like a fire hose they're drinking from, right? So, but I can certainly tell you that, you know, he is, you know, this is why he even ran for office. So I will do my bit, and I'm sorry if I let the ball drop, you know, Ebola and all.
No, no, you didn't. No, but I wonder if maybe that speaks to the bigger issue of when they're in Congress, maybe who they are is different, and maybe you could give us ideas for waking that up in them.
It could be, but I would just say this, you know, having a friend who I won't mention by name, but is the president of the World Bank, you know, there are, you know, they work in, you know, they go from being, let's say, a doctor in both those cases to being in a very large institution that they don't, you know, it's, you know, read about institutions you probably have. So, but I have no doubt that his passion for health and social justice is undimmed, and I don't have a hat, but I would eat it if I were wrong on that score, and I will reach out to him immediately. Just don't let me forget.
And let's take. So cool. Please go ahead. But let's take maybe 2 or 3 questions, and then we'll have some time, and you can respond. Thanks.
Okay. Paul, as you said, it was Haiti where your experience led to the birth of Partners in Health. You did an amazing job there. I used to be UNICEF representative in Haiti in the last days of the Duvalier regime, and one of the few good things that were happening in Haiti was the good work of Partners in Health.
Thank you.
And a wonderful thing moved on to Peru, Rwanda, and all over the world, and we all admire that work. Now,
thank you.
In the case of Haiti, where many of us have, you know, our heart in Haiti has gone through so many troubles, you had a second chance to go back to Haiti after the earthquake as Bill Clinton's deputy, special representative of the UN Secretary General, to try to help rebuild Haiti. It seems like this time things did not go quite right, and Haiti seems to continue to suffer. In fact, in my country, in Nepal, where we had a big earthquake last year, the common saying is, let us not repeat Haiti.
Yeah, for sure.
What happened? How come in your second inning in Haiti, we did not succeed? What are some of the lessons learned? Can you share that? I think that would be applicable for many other countries.
Well, you know, first of all, it really wasn't a second, because I never left Haiti. You know, I was just there, and as you can imagine, there aren't a lot of direct flights from Haiti to Sierra Leone, even though they seem to have no trouble getting Sierra Leoneans to Haiti and Cuba and Brazil. Never mind, that's a historical reference. And, you know, I'll tell you one thing. One of the biggest problems that I see, but it's not that different from Ebola. The pathology is in a lot of the so-called international community, right? Which is a very vague, sociologically indefensible term, right? But the rules of the road for a lot of emergency assistance and development assistance need to be rewritten. And certainly volunteer envoys don't write those rules. That's why Results is going to talk to some of the people who actually do. Now let me illustrate what I mean. After the earthquake in Haiti, if you track the money, and as far as I know, we're the only people who did do that. The little office we put together, right? And we being President Clinton and myself, we said, let's just track the pledges. And I said, well, are you suggesting this has never been done before? I mean, the tsunami in 2000, he said, yes, I am suggesting that. I just found that amazing, right? That really no one's like keeping count. And so we did. And then we said, and we were also going to see if the money really gets to Haiti, the pledges. And then we're going to see if the pledges get to Haitian institutions and what % of them do. And then pledges for rebuilding, how many of them go to Haitian firms, right? And then we have all those numbers, and to say they're a little disturbing is an understatement. As far as U.S. aid went, and again, neither President Clinton nor I are in the U.S. government. He was also a volunteer. I think less than 1% of the immediate emergency assistance aid went to Haitian institutions. Now, that you could say, well, the administrative capital and the nexus of the nation had been destroyed because it was predominantly the capital, right, and south. And just to give, I think most of you know this, but there are probably only 28 federal buildings in Haiti. 27 of them have collapsed. That means that my friends there in the Ministry of Health, and some of them your friends as well, 5-story building, 100 years old, it's 1 story the next morning. And some of you were there, so you don't have to imagine the utter chaos. I mean, telecommunications, et cetera, fires, and the place reeked of death for weeks. But we could have done better than 1%, right, to try and move. There were, we've been working on this a little bit before the earthquake, saying, why are there so many NGOs and we're not adding up to more than the sum of our parts? Which, by the way, wasn't particularly welcomed by the NGOs when they heard me say it. I got taken down publicly many times in meetings, public meetings. And I was saying, well, if the overhead of the NGO work is 40%, maybe that's too high. We found some that was 60%, okay? Because we were tracking that too. I did not win any popularity contests, let me tell you, my friend, during those years. And so we did what we try to do, is said, well, we'll do it ourselves. We'll build a major medical center in the middle of central Haiti, outside the earthquake zone, for the public sector, with Haitian labor, and we'll get our friends, who are in the building trades, from New England, a lot of them unemployed right now, right? Like I love the names of these unions, right? The International Brother of the Electric Workers. Is that like a 1930s Roosevelt-style electrical bolt? We had help because we had a lot of friends in Boston. Jim Mancera, one of my heroes, who had built up a construction company and then sold it. And I said, you bored, Jim? He's about my age. I got some really fun stuff for you. And David Walton, who some of you know, another may have been a classmate of Raul Ruiz's, by the way. And then Loon, who is a goddess, as I've already implied, and can get anything in and out of customs. Which I believe there should be a PhD in customology, right? But so we built our medical center. But I want you to come back. You'll be proud of it. I'm proud of the Haitians. I saw a patient there. May I? 2 weeks ago. They said, Paul, we have a Zika patient for you. I said, oh, really? A Zika patient? How do you know? And then they told me about this boy, a 12-year-old boy who was suddenly paralyzed, and it's called acute flaccid paralysis. And I went to see the boy. He had been there 2 weeks, and they had just had what's called a tracheostomy, so that they could take out the breathing tube. Now already you should be saying, my dear friend, who stood up for me in Nepal, you should be saying, wait, you have an ICU in central Haiti? Yes, we do. And he was admitted to the emergency room by an emergency room specialist. Wait, you have emergency specialist in central Haiti? Yes, we do. It was the first emergency medicine program in Haitian history. And the attending doctor, whose name is Cassandra, she's about yay high, like Loon, she's telling me the whole story. She gets a call from Port-au-Prince. This boy's from southern Haiti, Léogane, you'll remember. His poor mother, can you imagine? She takes him to the hospital. They said, nothing we can do. Hey, that's the Haitian symbol for there's nothing we can do. And then to Port-au-Prince, to a tertiary hospital. Port-au-Prince, mind you. And they called University Hospital Mirabale and said, we have a kid, we want to transfer you. So I said to her during rounds, why, Dr. Kassan, did they say they wanted to transfer this child to you? And she said, because he might need intensive care. And I hope you're thinking, wait, intensive care for 2 weeks And that boy didn't have a bed sore on him, right? That's a Haitian national institution built with money from the earthquake, which is reinforcing the training mission and taking care of poor people. That's the way we need to do, that's what we should do in Nepal as well. Build Nepali institutions to provide good care. Now I'm talking about medical care because that's my field, but I feel the same way about education. I was talking with, Ann Hastings earlier about some small and medium enterprise loans for businesses. And we've got to do better next time. And I'm just saying Ebola is the next time, right now. Right? That money that was generously pledged, we're not done with Ebola. How could we be done? There's still no health system there. These are the most, they're clinical deserts, okay? Especially Liberia and Sierra Leone, less so perhaps Guinea. That means that's why people die. They're public health deserts. That's why Ebola spreads. And it's the same for a bunch of other pathogens. So the Haiti lessons were those, the same ones I mentioned to Joanne. Use local partners. Build up national institutions. Have high aspirations, not this low-ball basic minimum package. And when we said we're building a university hospital in central Haiti, I mean, people scoffed. Not the Haitians, by the way. They're like, yay, build a hospital. I'm talking about the experts, my friends, and your friends too, They didn't scoff to my face always, but, I could hear the snickering from all the way up in central Haiti. This is not a priority. It's not cost effective. It's not sustainable. It won't be maintained. Well, now we're 3 years later, and it's the biggest training program for doctors, nurses, managers, technicians, and we're about to open a national reference laboratory. And we can tell if it's Zika. Love, Paul.
Hello, I'm Georgia Genoe, and I'm from Liberia. So I
You're from Liberia?
Yeah, and if you're looking for friends, I'm one of them.
Can I friend you?
I'll think about it.
The Liberian response is we'll palaver about it.
So I believe, if I don't ask, you this question, I'm going to be doing injustice to Liberia and to neighboring Sierra Leone, since you've talked a lot about Ebola in Liberia and in Sierra Leone. So just to give you a background, I was in Liberia when the Ebola crisis started. I lost a lot of my friends from college and from my community, people, maybe over 12 persons that I have personal connection to.
Yeah.
And then I moved to the U.S. in August. That was in the heat of the Ebola crisis. So I literally had to pay $3,000 plus for my ticket because no flight, almost all of the flight had gotten canceled, and I had to be in school. So my question is, if upon hearing the first case in Liberia or in Sierra Leone, what could you have done differently to stop the spread? One, to increase education and improve treatment. So if you were reversing everything from the beginning, because when I was in Liberia, my mom came to me one day. She's a really traditional person, and I was very scared of everything that was going on. I used to walk in the street with thick gloves on my hands and sometimes wear plastic over my shoes because I wanted to be safe as possible before getting back, coming to the U.S. and being transferred back to Liberia. And then my mom would say, these people, they're only trying to make us to hate one another, not to shake hands, not to hug. It's not because the sickness is real. And I told her, Mom, the next time you leave my apartment, you shake anybody's hands, you come back, you're going to stay away for 14 days before you enter the house. And I was serious. I didn't let anybody into my house, because I was really afraid of everything that was happening. But I was just one person among the millions of people in Liberia who would take it really seriously. What would you have done to really stop everything that was going on? We're just 4.2 million people, and the virus spread really quickly, and a lot of people died. So just to back up with that question, what are some of the political constraints, or what some of the political constraints that limited international doctors and international organizations like Results or international government from actually stepping in before the situation got worse?
Those are great questions, and I would ask that you meet. Is Maxo Luma Koteuyela? So this is someone you should meet. One of my Haitian doctor colleagues who's with Partners in Health in Liberia. It's just a good connection to have, and a more than 10-year veteran of Partners in Health work. I don't want to get theoretical, but I think one thing that's important to say, and if you go to, let's say, Berkeley, California, you will find that people have a lot of strange ideas about what causes disease. You know, like crystals and things, okay? You know, it's everywhere in the world. And what the claim that bothered me, and can I ask your first name again? Georgia. The claim that bothered me early on was that there is a causal relation between what people they believe about illness, and you know your own mother. I don't know her, but let me just make this theoretical point. It's important that what they say causes illness, and whether or not they seek care or try to avoid illness or injury are not neatly related, right? So what bothered me coming out of Africa in the news media, it's about bush meat and exotic funerary ritual, but we call bush meat in the United States, we call that game, and funerary ritual, we call that funeral. You know, this exoticization of Africa, and suddenly what people's ideas had about Ebola not being real were more important than the material discussion of where's the staff, stuff, space, and systems we need to fight back. And they were absent. Right now, there are fewer than 50 physicians practicing in Liberia. That would be about a dozen in Boston, and I can't move 5 feet in my office without bumping into a dozen doctors. All right? So I'm not saying that what, you know, culture and belief and cosmology are irrelevant. They're certainly not. But to suggest that it was predictably, and I think, you know, you can use the R word, I think the idea that that was what caused this explosive epidemic is false. The epidemic was spread because, as I said, it is a public health wasteland, desert. There's no labs, so you can't know what's killing you. There's no people being asked to be community health worker volunteers. Like, you know, like we pay ourselves, but we want the poor to volunteer their service, right? How many times have you guys fought against that as results? And so the international, that's one part of the problem. Now, if I'm allowed to back up just a little bit, you say, what would I have done differently? Well, if I were the dictator of, you know, Ebola preparedness for the world, or just Liberia, after the war ended, I would have said, you know, it's true that we needed international peacekeepers, and a lot of them, to end the war, because by this time, it wasn't 2 wars, by the way, it was 1 war. So it was the Diamond War in both countries. It wasn't only about diamonds, but it was about other extracted things, hardwoods, iron ore, things I don't even know what they are, rutile, bauxite, you know. That's what it was about, largely, and it was a 10 years, and in every other single country, many of them you come from, they were all involved in it. Nigeria had like a quarter of its armed forces in Sierra Leone at one point, just before the second Battle of Freetown. And the big major powers too. I mean, they weren't manufacturing those weapons in Liberia and Sierra Leone, right? So all I'm saying is, after the war, that was the chance. Like after the earthquake in Haiti, as my friend said, there's your chance. But if it's all put into martial and military responses, and none's left over for healthcare and education, then you got a problem that's going to be called Ebola, Lassa fever, undiagnosed malaria. I could go right through the list. It's my field. You know, I can show off by naming 20 different pathogens that could, kill you and look just like one looks like the other. That's where I would have wanted to step in if I had one chance, right? By the time you're talking about the summer of 2014, there was no way that Ebola could be contained and kept out of the capital cities and the big cities on the coast. It went just like the rebels, east to west. There's no way to stop it. And guess what they've tried to do to stop it for 100 years? It being sleeping sickness, well, even malaria, plague, bubonic plague. It's always the same playbook, the colonial playbook. Contain, surround, isolate, punish, right? Smallpox. It's 100 years of this just during the colonial occupation of Sierra Leone and Guinea. And the Americo-Liberians kind of occupied their country, right? So this is an old playbook. There's nothing new about it. It does not involve integrating prevention and care, like PEPFAR and the Global Fund. That's a big step forward for public health. We're saying, you know what? People are not keen to be isolated as a service to others. And they go into a room where there's no food, there's no staff, space, systems. How many of these patients that Byler and I took care of or interviewed said, well, we got there in the night, there was no electricity in the, Ebola treatment unit, was a little bit short on the T in the ETU, and no food. I like that you like my humor. You got to have it to survive. So anyway, all I'm saying is the intervention that I would have made would have been after the war to say, we really do need peacekeepers because this war is vicious. It involves 150,000 combatants and those all across the region. But we've got to have some investments in human security, jobs, healthcare, education. That's the social justice angle. Now, having not been there then and being there now, I will say this. We're going to make that argument, but we need your help. We're saying you can't use martial responses for epidemic disease. They tried to segregate Freetown from malaria. It's transmitted by a mosquito. They can fly. I'm sorry, I get carried away by this stuff. I'm just getting warmed up, so don't rush me.
Hi, my name is Stephen Blowbaum. I'm a new expert on poverty. I'm from West Des Moines, Iowa. As a fellow white male of privilege, how do you...
Yeah, but you look better than I do.
Thanks. Flattery will get you everywhere.
And I beg your pardon, the Haitians told me I'm a pink male of privilege.
Oh, okay.
Therefore, a person of color. Pink color.
How do you personally engage with our fellow white men of privilege, and especially those that are living in denial about it?
Yeah.
That's my quest for the conference, is to figure out how to engage my fellow white man of privilege and not wring their necks.
Yeah. That's actually not a useful strategy usually. It's a great question. I think, I'll say one thing. Remember, as a physician, I don't really have a lot of patients who are white males of privilege. I have in the past, but, not so often. And also, the people I get to work with in Haiti, Rwanda, Malawi, Lesotho, Sierra Leone, Liberia, they already know the pathology of white supremacy. Forget about privilege. So they don't need any teaching, and they teach me. But as a teacher at an American university, a small community-based college in Cambridge, Massachusetts, I do believe that, this insufferable WL expression, white liberal expression, you go to where people are at. That's what Joanne was saying about there are some issues that must transcend partisan debate. And I think it should be a very large set of issues. People should have the right to safe housing, security, as the sort that I talked about, a decent job, etc. Freedom from persecution and lynching and neo-slavery, and on and on. But I think, you know how it's often not very fruitful to have arguments with your brothers and sisters? Did you ever learn that? It's not really data-based. And so I think, argument is important, right? It's important to hone your arguments. Like, I could give you chapter and verse, as I just started to, about the history of epidemic disease control in the Upper Guinea coast of West Africa. Ask my students. So it's good to be armed for it and be prepared, for it. But I think as a teacher, I try to use history and personal narrative, just like Joanne said. Now, the first time I tried to do this as a teacher was in 1987, when I was able to design, as a graduate student with my mentor, a course called, get ready for this, Varieties of Human Suffering. Let's just say it wasn't a big hit. We watched all of Shoah, the movie. I said, no, you have to watch all 12 hours. I didn't get very high ratings as a teacher. But the idea is a good one, right? Narrative, slave narratives, reading about the suffering of people unlike you, right? And, that's a very privileged group of people, right? That's why we also built a university in Rwanda. That's why we called the hospital in Haiti University Hospital. By the way, people said, you can't name it University Hospital. There's no university here. And we said, oh, but there will be. So thank you. And now finally there's echoes. So I guess what I'm saying is, in a church group or a civic group, or I'm sure you're a member of the Elks Lodge, or, various white people organizations. I was just being funny. The communities that you are part of, right? And it sounds like a thing a professor would say, right? But that's why we started the Institute for Health and Social Justice. We sat around and we talked about racism and gender inequality for a whole year. Now, we were doing other things, seeing patients, working on staff racism, but it's a pretty large nexus of people now. I mean, you just heard that one of my students is a congressman. I mean, he was part of one of those groups. It's all over the world because we work in a dozen places, and it doesn't sound very fiery, right? It doesn't, but I think those natural communities of concern, we're all part of them, right? We all do have groups of affiliations. Just reading about Orlando in the New Yorker today, they're in Talk of the Town, which is at the beginning of this magazine, American weekly magazine. I think it's a very reliable and great place to, get information. But there was a vignette of an LGBT, I always get the order wrong, LGBTQ, or I could switch it around, bar in New York. And reading it, you say, well, there's a natural community of concern, right? There's where friends, another WL term, feel safe. And, that's the tragedy of Orlando. They weren't safe, right? But everybody belongs to, it may be a church group, it may be something on a university campus, it may be, and the list is obvious. I've been accused at Partners in Health of giving too many talks. They're like, you'll even give a talk to the Girl Scouts. I said, I gave a talk to the Brownies, actually, last year. So I believe in that. I believe that the Black Lives Matter movement is important in part because it's so fueled by youth as well, right? And results, look at this room. It's not a bunch of, you didn't say it, but old white guys of privilege. Look around. We're surrounded by young people. And I think that's a very important part of the struggle against racism. Brian Stevenson, who's on the board of Partners in Health and another hero of mine, wrote a great book. You can applaud my books too, hey. I'm kidding. It's called Just Mercy. And I would just recommend, take a book like that and to your community of concern, the Kiwanis Club, the Knights of Columbus. the benevolent protective order of the Elks. I can go on. But, and then, that's where a conversation about white supremacy and white privilege can and must happen. And I think that's one thing I would consider very strongly.
Yes. So we're getting close to where we need to wrap up. So I'm going to take, if you could ask your question, I'll take one more question. So we'll take two, and then Paul, kind of final kind of comments and responses.
Or being in the equity mode, you had already told me to say them together. How about if I promised you this is the most amazing summative answer, and they all got to do their questions in the interest of equity, please? No, I'm kidding. I'm just a guest here.
So welcome, Dr. Farmer. My name is Jim Driggers. Thanks for being here. My question, I'm from California. My question is, I'm about to meet with a representative's office in which the representative honestly, truly, fundamentally believes that foreign aid should not be the province of the government. It should be the public, private donations, essentially. So given that's the mindset to begin with, is there information, and I'm questioning whether facts and figures will affect this,
I
but
get you.
What suggestion can you give to open up the idea that it is would be wise to invest government money into foreign aid? I'll leave it at that. Just a very simple question. Thanks.
Thank you.
Hello, Dr. Farmer.
As if. Hello, Ms. Hastings.
My name is Ann Hastings, and I'm with Uplift, and we're working hard to accelerate the global adoption of the graduation approach, which you know very well from Haiti and Foncosé in Haiti and the Chemin La Vie Mio program, which translated is the pathway to a better life. You say often, poverty causes disease. I think that's how you put it.
And disease causes poverty.
And disease causes poverty, both. But the two are intimately connected. Why can't we imagine a world in which we had both the Global Fund and PEPFAR and a global fund to eliminate extreme poverty? Could we do that? And could all of us here in this room today say we are not only going to fight for the renewal of the Global Fund for diseases, but we're going to fight for a global fund to end the poverty that is doing so much to create these diseases? And then instead of 17 million or whatever the numbers are, we can double or triple that.
Do you want me to give these a shot, or I do what I'm told?
So they're telling me 1 minute. So I am going to say, if you guys literally have one sentence questions,
but I still get to answer.
Ask one sentence.
My question is, what is Partners in Health looking at doing going forward about helping treat or prevent chronic diseases like heart disease and diabetes that are starting to wave through middle and low-income countries?
Great.
That was concise.
That was.
Love it.
You mentioned earlier, Dr. Farmer, how important it is to stay optimistic in your line of work, regardless of what kind of assistance that may require. How do you do that, especially in the face of so many varieties of human suffering?
None of your business.
So my question has to do with the drugs and TB. There haven't been any new drugs on the pipeline for 20 years, and what can we do to encourage drug companies to do more R&D and produce more TB drugs?
Yeah, that's great.
Very concise. Great question.
If I could go in no particular order, because I think the TB drug story there is a bit of a breakthrough, as you probably know. There are 2 new drugs, the first ones in 40 years, right? Bedaquiline and delamanid. And it would be wise for activists from results to become familiar with the names, the manufacturers, et cetera, because the implementation challenge is going to be massive, right? They've already been, now we're in our, 3rd, 4th year since, and like 12 people have gotten them who are poor. It's like, it wasn't hundreds of thousands, by the way, in 2002 who were on ARVs. I'll bet you it was a lot less than that in the sub-Saharan Africa, unless you were middle class. And that's like also 12 people. No laugh? So let me say that my colleagues from here, from Peru, for example, you should meet them because they know an awful lot about this. Also, my colleagues from Liberia, because we're just now getting the meds and enrolling people, but we need help, social supports, for the reasons that Anne mentioned, for the patients, right? They're also chronically ill, some of them are homeless, right? They're feared because they're carriers of an airborne lethal disease. So I hope you'll find that good part of the results conference. But the word chronic, I'm sorry, can I ask who asked that super concise, great question? Lisa? So anyway, if you open a clinic anywhere or a hospital, you're always going to see chronic disease. So we've never not worked on chronic disease as partners in health. HIV and tuberculosis may be infectious or an etiology, but they're chronic diseases. Major mental illness, diabetes, and the kind of heart disease you see among the bottom billion, they're completely different and a huge burden. And the technical information on the Partners in Health website is really pretty good, I think, on the chronic disease movement. And let me just say this for the social justice people here, and I swear I'll be short. The whole approach of the international community on chronic disease is very anti-poor, right? It says, don't drink, don't smoke, exercise, and eat less. Hello, they're not drinking, they're not smoking, and they need to eat more, okay? And they exercise all day long, toting that barge and work hoeing the ground. So please, don't say that when you're talking about our people. And that's a major advocacy challenge. And read some of the stuff by PIH stalwart Gene Buchman, B-U-K-H-M-A-N. Now, Anne, I wanted to say, well, first, seeing a congressman about foreign aid, if that person has already decided that it's a waste of time, I would spend more time, like, I don't know, bring him a hunting trophy or something. Like, be his pal. Because, there's not a lot of evidence that half an hour you have to do it over time. And Joanne says these things more politically correctly than I do, but there are 3 ways I think that the social justice community should know how to defend good transfers of wealth from rich to poor, right? We don't even call it aid. We're like, let's go from aid to accompaniment. But that's a conversation he might not be interested in having. But there's 3 main things that we've learned to do. And don't forget the PEPFAR story. I mean, I went in there thinking, really? George W. Bush is going to be like the big advocate for people living with AIDS in the world, the poor world? Really? He was, okay? Admit it. PEPFAR is... And Josh Bolton, Michael Gerson. I mean, I wouldn't even, I can't believe I even know their names. But they came through for us, okay? And that doesn't change all the other things about that administration. I'm just saying, remember that what Joanne believes made a big difference was before and after. Someone who's shriveled up and dying of a consumptive disease, in this case always 2, HIV and tuberculosis, and look how it works when you actually treat them as your equal and give them the same care you would give your brother or your mother. That was deeply moving to them. Now, I would call that a human rights argument, one of 3. the human rights argument. People deserve, they deserve to be treated like equals. We're supposed to fight to believe that when we doubt it. Second, economic arguments. A lot of these guys, including gals, heads of state and dignitaries, when you say, you invest in this and you'll reduce poverty, it's true and there's ample evidence for it, and that includes investment in safety nets, universal health care. It's a great way to improve the economy. Every experiment over the last 100 years shows that that's true. So one's human right. Second is this sort of economic argument, really development arguments. Third, I don't ever use, if we don't do this, Ebola is going to come to suburban California, Orange County at great risk. I never do that. And that's a very common one. I think it's stooping low, the security arguments. They can be useful, but don't worry, other people will say it. You don't have to waste your social justice breath on that. But there are people who believe that there are such things as public goods for public health, right? The public health Luddites. My audience is not laughing. The public health minimalists still believe, that you ought to have clean water, except for in Flint. But anyway, you do your homework, but don't come in swinging with one of those three. There's got to be some way to get to this guy. And again, I'm just really humbled by having good coaches who said, this is what this person cares about. And I'm pretty good at taking orders. Ann, I'll tell you, and in closing, reluctant though I am to close, I think on this score we should be self-critical. When you say it's how can we make this not just about the replenishment of the global fund, but the creation of a larger pie to fight extreme poverty. I believe in that, right? But you know what happens a lot of time in our circles? It becomes AIDS versus chronic disease. And you're going, AIDS actually is a chronic disease. It's mental health versus cancer. And I go all the way into the weeds. Like, it's breast cancer versus lung cancer. These pathologies are not at war with each other. They're at war with humans, okay? Poverty, gender inequality, racism, homelessness, displacement, war, all these diseases we're talking about, lack of access to prevention, they're the enemy. And what we too often do is pit one good thing against another. And they've won already, right? They're saying, well, you can't have that. We're living in an era of limited resources. And somebody ought to be saying, yeah, but they're less limited now than ever before in human history. Hello? And we're not doing it. We're saying, oh, well, my program's important. Pitting microfinance against, access to fertilizer for poor peasants, or whatever, that's the term they use in Haiti, for poor farmers. Oh, he already said I'm a rich white farmer. I mean, this is a mistake we make all too often in our world, and I think we should resist it. People should not have to worry about dying of, cervical cancer at 30 years old, any more than they should have to worry about dying of drug-resistant TB or diabetes or paralysis from Zika. And that's the fight. That's the only. I think that's the only fight worth fighting. The fight for equity and social justice. Thank you. Thank you. Thank you. Thank you. Thank you.